Thank you, Claire, for that introduction, and good morning, all of you. It's really great to be here, and it's really great that the conference is starting with a patient perspective, the perspective of patients and families. Now, in case you're wondering, I do have my personal stories to tell, my own and family's experience of patient safety incidents, but that's not the reason I'm here, and I'm not going to dwell on my stories. Perhaps I should tell you a bit about the charity so you get the context that I'm coming from. We're an independent charity. We are the charity for patient safety and justice for the UK as a whole. At the heart of what we do is support and advice, specialist advice, to people who've been affected by lapses in patient safety, by patient safety incidents, either the patient themselves or their families. And it's those daily conversations, every single working day, we're speaking to people whose lives have been turned upside down or devastated by avoidable incidents that have caused harm or death in the NHS. That's what gives us our passion for what we do. It also gives us an incredible insight to what those people's experiences are and how their experience, even after an avoidable incident, could be made so much better. In case you're thinking this is a slightly scary type of organisation, because we do tell people about their rights and we help them exercise their rights after things have gone wrong. We're also passionate about working in partnership. We work in partnership with health professionals, the NHS, regulators, and even lawyers to try and make things better. Influencing is at the core of what we do because we can help so many more people by bringing about changes in policy and priorities than we can through our very limited resources, providing direct advice and support to those people who've been harmed. So those of you who do know about us may have heard of us in the context of the Mid-Staffordshire inquiry, where we were a core participant. Francis took on board the vast majority of the recommendations we encouraged him to take on board. And perhaps the most famous campaign of ours of all was the campaign for a statutory duty of candour, which is now in place in England, Scotland, and soon to be in Wales and Northern Ireland as well. Why is that important? Well, it's all part of the way we see culture through the lens of patients and family members. Now, there's great momentum in the NHS at the moment to work on just culture. But what really strikes us is that so often the patient or the family is missed out of those conversations. We'll be hearing from Denise Schaffer later on from NHS Resolution, who's done some excellent work and produced really good guidance for NHS trusts. But that, I think it's fair to say, mainly focuses on telling employers, providers, how to be fair to their staff, something we're passionate about and absolutely needs to happen. What we think is needed is to have a proper just culture in healthcare. It has to be relevant, directly relevant, both to patients and families as well as staff. And that's the element that so far is so often missing or weak in the national discussions about this. So it's not just about being fair at the local level as well, but you know, the NHS trusts and providers, clinics and practices where you work. It means taking on board what just culture means at the very top, right up to government, perhaps instilling it as part of the NHS constitution and having a single nationally agreed definition of what we mean by just culture, because it does mean different things to different people. So how would things, for example, be different for patients and families if that was already happening? If before introducing any new policy, for example, institutions or politicians thought about what does this look like through our lens of, is it a just and learning culture that's being promoted here? If we did, I wonder whether we would even have things like policies on safe space, as was originally discussed. You remember the debates about safe space where the original proposal was that this was a prohibition on sharing information, a legal prohibition on sharing information from NHS safety investigations, even from the very patients or families who are being affected. We had to do an awful lot of work, and thankfully we persuaded government to actually change the element of that was to apply to local investigations, primary investigations into people's incidents at the local level. It now just applies and will apply to the HSIB. But how could people be promoting something that quite clearly was in direct contradiction to the statutory duty of candour in the context of a just culture? We'll be hearing a lot over the following months from government about how the current situation about compensating people who the NHS has harmed, not intentionally, but through a variety of reasons, one of which I'd argue is a lack of investment, having enough staff, having staff of the right type, having enough training and support for staff. Basically, we're harming too many people, and a lot of those people need and have the right to compensation. So we'll be hearing words from government like, this is unsustainable. We'll hear words like, we need to strike a balance between access to justice for the patients and families who we have harmed and the cost to the NHS and the government of compensating those people. Be wary of those words, striking a balance. It has a ring of reasonableness about it. If you burrow down, what that actually means is, because the government is struggling to meet the cost of its own mistakes, or the NHS's own mistakes, the proposition is that we'll have to compromise on people's access to justice. People simply won't be able to get access to justice in the way we currently expect. And actually, as an NHS patient who's injured, you'd have less rights than an injured person in any other part of society, where our culture is that if someone's harmed you negligently, you get compensation. What that could also do is really have an unintended consequence about the atmosphere, the culture in which you all work and that patients experience when they come into your institutions. If people feel they're being unfairly treated, if things are not coming to light, if people aren't able to challenge initial beliefs that no mistake was made, that this wasn't avoidable, etc., which people are currently able to do, then not only will that make it a very uncomfortable atmosphere and culture, it will mean that we don't learn lessons from those cases that aren't initially recognised as being avoidable. So it would be a much better place if we can get this joined-up approach. At the very heart of a just culture is, of course, openness and honesty. That's why we campaigned so vigorously and for so long to get the statutory duty of candour. And if we get this right, and it's still early days, it will be the biggest breakthrough in patient safety and in patients' rights that we've ever seen. It's remarkable it took so long and we faced such resistance for so many years to bring in this fundamental right and duty. It's there now, but we still need to do an awful lot of work to make it a reality. There's still a lot of confusion about what it actually means. Too many staff and boards have not had proper training on what it means and how to implement it compassionately and proportionately and meaningfully. There are things like people misunderstanding that it appears to incidents that simply appear to have caused harm. It doesn't have to be proven. Causation doesn't need to be established. It's about basic honesty, that there's something to be looked at, investigated, and people need to know all of the issues and all of the facts that they can be shared and should be shared. So the other thing about this, and reports of ours, if you've seen them, have pointed this out, to make some of these initiatives, whether it's just culture or duty of candour, real, they also need to be made to stick. So we'll be hearing from the CQC very shortly. And so much rests on people recognising these are must-dos and not simply guidance, and people seeing consequences when people don't live up to the standards that have been set. This is my nightmare vision of how the NHS might be dealing with the duty of candour in practice. There's such a lot of focus on the definitions, the precise definition of moderate harm, and whether the argument can be made. This is meant to be lawyers and doctors getting around the table. We know we've harmed someone, but can it be argued this is low harm, that we don't actually have to follow the duty of candour? Of course, that's not the spirit behind the duty of candour. And it'd be an awful waste of doctors' and nurses' time to be drawn into those kinds of discussions. If there's any doubt, just explain it to people. Assume that it is covered, because that's the natural right thing to do anyway, to be open and honest. This is another nightmare vision of how it might look in practice. As you know, it requires a formal letter, a duty of candour letter, to be issued. That's the way that the DOH at the time designed it in the regulations. It wasn't our doing. And I haven't actually seen a letter that actually uses these precise words, but I've seen letters that more or less are the same as this. Dear Mr. Smith, in accordance with Regulation 20 of the Health and Social Care Act 2008, I hereby apologise. That's not a meaningful apology. It doesn't show insight. It doesn't show empathy. And that's what we need to avoid to make it real. Talking about making things real, there's been a lot of progress on a lot of fronts in patient safety, but investigations are a real cause of concern. A recent report by NHS Resolution had these startling statistics about the large number of patients in their early notification scheme, families in the early notification scheme, who hadn't even been told that there was an incident, and a startlingly low number of people who'd been invited to be involved in the investigation, despite all of the guidance, all of the previous reports, in spite of the statutory duty of candour, which was in place at the period of time that this research covered. Quite startling, so a real reminder that there's a lot more to do. There's many ways that patients can actually be put at the centre of patient safety. It doesn't all have to be after the event, but that's where I'm focusing, because I think that's where we really have to make improvements as a priority. But there are good proposals in the NHS patient safety strategy for England. For example, there's a proposal for patient safety advocates, a network of them to be developed nationally to work with patient safety committees, clinical government committees and staff, etc. A really good idea. It was recommended over 10 years ago by Sir Liam Donaldson. Let's hope it actually happens this time. One worrying thing that we've learned about this is that, surprise, surprise, it's meant to happen at no cost to the government. You, people in the NHS, your trusts are meant to make it happen using the resources already at your disposal, which, as we know, are very stretched. That does almost beg a belief that we can expect a really big cultural change and development of that kind to be done properly without proper resourcing. When it comes to patient safety investigations, we're eagerly awaiting the new serious incident framework, although it's going to be called something else. Actually, the old serious incident framework was pretty damn good. It was good at what it said about involving patients and families in investigations. The problem with it has always been is that it's not consistently implemented. Again, it's not good enough just to have the documents, the guidance, the policies. It needs to be made to stick, and it needs to be consistent across the country. What meaningful involvement investigations should involve is all of these things. Signposting to specialist independent advice to help people navigate these procedures and investigations. Being kept informed of progress, not just sight of the terms of reference, involvement in setting terms of reference, having access to any relevant evidence that comes about, and the opportunity to comment on the draft report, etc. Some people do this well, an awful lot of people don't do it well. It's inconsistent and it needs improvement. one last point on this. The guidance and the understanding out there that people need some specialist independent advice and support when they're faced with these terrible situations. The realization and the guidance is there. You know, you should signpost people to independent advice and support. The trouble is, again, surprise, surprise, there is no budget for it. Whilst we have an independent advocacy service for complaints, which could range from anything from, car parking, food in hospitals, etc., all very important issues. For serious incidents, those that are subject to investigations, there is no funding made available. And one of the things that I think will be a massive step forward is if we collectively can get to a situation where that really specialist, independent, relevant advice and support is available to every single family or patient who needs it, who's faced with a patient safety investigation. That's just a snapshot. I hope it's given you a flavour of what we see as being some of the main priorities in patient safety. I understand that there'll be a question and answer session after our next two speakers, and I look forward to hearing from you then. Thanks very much for your time.